Welcome back to this afternoon's session, and we've got an interesting session this afternoon, how to implement prevention, meet the experts. And we've got 3 experts here today for you to talk to. We decided against doing interactive voting, but there will be some questions that the speakers will ask, and we also welcome your questions for the speakers during or at the conclusion of their presentations. So the first speaker that we have is Andrew Grulich. Andrew's Professor and Head of the HIV Epidemiology and Prevention Program at the Kirby Institute of the University of New South Wales. And he's going to talk about implementing PrEP and adapting guidelines for local use.
Thank you, Steve. I'm going to continue my talk from this morning. I'm going to assume you were here this morning. I hope at least the great majority of you were here, because I think you'd find it very dull if I just repeated what I said then. This is advertised as a Meet the Expert session. Now, I don't hold myself out to be an expert on all matters of PrEP, and I'm sure there's a lot of expertise in the audience that we can make use of as well. So what I thought I would do is talk about some key considerations for setting up PrEP programs in the areas that you're from, that people are from. Talking about guidelines about who should receive PrEP, talking about what happens when you first see a person for PrEP, the follow-up testing, what do we do to ensure adherence, and something that I think rises for many people in this area is how are we possibly going to take on this huge extra workload of HIV-negative people requiring antiretrovirals. So I'm going to give a little bit of presentations and sometimes use examples from Sydney and then ask people to contribute data from where they are. So I hope this works. If not, it's going to be a pretty quick presentation. We'll see how we go. So who should receive PrEP? So the WHO recommendation, which was released in 2015, is that oral PrEP containing TDF should be offered as an additional prevention choice, so not on its own, for people at substantial risk of HIV infection. And they say that, and was certainly based on a strong recommendation based on high quality evidence. And their provisional position was that that substantial risk of HIV infection would be defined as HIV incidence of greater than 3 per 100 person years. But the thresholds might vary depending on other considerations, including resources and relative costs, demand for PrEP, and other opportunities. Now, the World Health Organization stated that they, in that 2015 document, that they would release detailed guidance on PrEP in 2016, which they haven't done yet. So hopefully it's on its way, and it's coming out soon, because I think a lot of people working in the field would actually value some guidance as to how to interpret these overall recommendations. So I wonder if there's anybody in the audience who'd like to contribute to the discussion about how they've decided in their area who's eligible for PrEP. Do you have local incidence data? It's not very common, incidence data, and sometimes you have to use prevalence data. So is there anybody out there, and I'll give you an example from Australia if we can't get this going yet, but is there anybody out there who'd like to talk about what's happened in their own region about working out who might be eligible for PrEP and using incidence or prevalence data? I can't see a rush of people for the microphones. All right, so look, what I'll do is give you an example from how we did this in Sydney, and then hopefully that might prompt some discussion. So you saw this graph this morning. We've got flat notifications in Australia. They're mostly men who have sex with men, and we're approaching the 1990 goal. So one thing we could have done in Australia was to offer it to all men who have sex with men. Now, we estimate that's about 5% of the population. 5% of the population, of the male population taking PrEP, is a lot of antiretrovirals. It would be very costly. It would be not particularly well targeted, because we know a lot of men who have sex with men are not high risk. And so we wanted to use incidence data, and we were in the fortunate position in Australia of having incidence data to base these calculations on. So when we did this cohort study, and it is almost 10 years old, the overall incidence in gay men in Sydney was about 1% per year. So that's well below the threshold that the World Health Organization suggests. But we looked within our data at risk factors that we felt could be operationalised into a guideline. And you see them there, that if you're a regular partner of an HIV positive man and have some condomless sex with that man, you had an incidence of 5% per year. If you had receptive condomless sex with casual partners, so that's in the receptive position, you had about 2% per year. Interestingly, if you had only insertive condomless sex, the risk was much lower. If you had rectal STIs, then you see the incidence is really quite high. Rectal chlamydia, 7% per year, gonorrhea, 7%, chlamydia, nearly 4%, and methamphetamine, about 2% per year. So this is what we took as the most easily operationalised risk factors, and we wrote them into our guidelines. So for HIV-negative gay and bisexual men, our guidelines state that if you have an HIV-positive partner, a regular sexual partner who is not on antiretroviral therapy, you're eligible for PrEP. That's actually a very small group in Australia now because we essentially have a test and treat environment. So as soon as a person's diagnosed, the great majority of people go on treatment immediately. So that's a very small group. The biggest group is those who report receptive condomless sex with casual partners in the last 3 months. Anal STIs, we don't say any STIs because, again, our data didn't show that urethral STIs were related to HIV risk in the last 3 months. We added syphilis because, in our setting at least, HIV-positive men have a lot of syphilis, and it's often a marker that a negative man is having sex in that environment. And then methamphetamine use. So there are our guidelines for gay men. Even in our setting, we do have some heterosexual transmission, of course. But not much. We can't identify any heterosexual community in Australia that has a high enough prevalence. We don't have incidence data in those populations. But we said, of course, that if you have an HIV-positive partner who's not on treatment, then that would be a reasonable situation for PrEP. But again, that's very rare because most positive people get onto treatment. For injecting drug use, in Australia we have very good access to clean needles, and so in most situations PrEP is not relevant because people protect themselves from HIV through the use of clean needles. But we've allowed people to get on PrEP if for some reason they're not accessing clean needles, but only in those situations. And I must say, in the rush to get this started this year, and it certainly was a rush, we didn't write this out very well for transgender people, but we're now fixing that so that to ensure that we have good inclusion of transgender women and men in our guidelines. So before we move on to what happens at a baseline visit, is there anybody who would like to share their experiences or ask questions about how to choose who gets PrEP? Is everybody clear, given the evidence on PrEP, who they would want to start PrEP on in their setting? There's a question over there.
Yes, sorry, Andrew. Where do the sex workers, male or female, fit in this list?
In Australia, the sex worker situation has been very controversial. So we've managed in Australia to maintain extraordinarily high levels of condom use with sex workers. Sex work in most states of Australia is legal, and use of condom is treated as an occupational health and safety issue by sex workers. The sex workers are very organised about this and very rightfully proud of their achievements of very high levels of condom use. The sex workers in our settings are very concerned about PrEP because they feel it might undermine the culture of complete condom use with sex workers. And so they are against PrEP use in our setting. Now, if there was a situation where somebody was a heterosexual sex worker and believed they were being exposed to HIV, then they could come into these guidelines under the heterosexuals. Any other questions or points? Okay, so let's move on to what happens at a baseline visit. So there's no getting around it. The baseline visit for a PrEP is a little bit complicated. It's the only visit I think you will find in a PrEP program that takes considerable period of time. After that, it's very much quicker. In our setting, well, in any setting, you should be doing, in this situation, the highest sensitivity HIV test that you're able to offer in your setting, because you really want to exclude the fact that a person might have recently acquired HIV before you start them on PrEP. Because if a person, for example, has been infected for 6 or 8 weeks and it hasn't yet shown up on your second generation assay, then you're exposing them to 2 drugs while they've got high viral load, and that's a situation where you might cause viral resistance. So in our setting, we certainly demand a 4th generation antibody antigen test to be negative before we start on PrEP. If somebody comes in reporting that they've had condomless anal intercourse in the last 72 hours, then we will consider starting them on PEP, 3-drug PEP, and then transitioning to PrEP after a month. Now, I'm aware that in many of your settings you won't have access to 4th generation antibody antigen assays, and that's where the visit at 1 month is very important to confirm that they're still HIV negative at the 1 month visit. You should test for HPV, obviously, at baseline, and vaccinate if they're not immune or infected. STI testing where possible. We heard from Dr. Nitya this morning that there isn't generally access to nucleic acid testing in most parts of the region. And the World Health Organization does recommend that you test for renal function at baseline. There's really no getting around that. It is an issue, and one that it is a test that needs to be done. Any questions about that at the baseline visit? Please come to a microphone so we can hear you, though. There's the front microphone, please. Yep.
Check. Yes, just one quick question. Why just hepatitis B and not C?
So in our setting, we actually do test for hepatitis C. It's been a bit controversial in our setting because for HIV-negative gay men, we don't yet see much sexually transmitted hepatitis C. Actually, the point has been made quite forcefully in Australia that PrEP is likely to break down sexual barriers between HIV-positive and HIV-negative men, and so we may begin to see more hepatitis C transmission. In our setting, we do test for it at baseline and occasionally at follow-up, but not as frequently as the others. So if you're it's a good point, if you're in a setting where sexual transmission of hepatitis C is happening in gay men, then you should be testing for it at baseline.
I was thinking also people injecting drugs, actually.
Yeah, absolutely. Sure. Yeah. Sure.
Dr. Usgare from Bombay, India. Question is, you are testing creatinine only for TDF, isn't it?
Sorry? Every 6 months. Well,
no, but only in the eventuality of taking TDF.
Yes. Yeah.
If a person is already having some problem with kidneys, then you definitely have an alternative for that. So
Yep.
will you be using zadivudine, lamivudine, something which was done prior to all this, prior to TDF? So in that case, you can change the combination of your PrEP.
Well, it is an issue that in people with renal dysfunction, there is a problem with using TDF, absolutely. However, there's no randomised trial evidence for PrEP regimens using drugs that are not based on TDF. There is currently a randomised trial going on in Europe and North America using TAF, the new tenofovir-related tenofovir drug. But there is, as yet, no randomised trial that's data that's effective.
But for PEP, we were using zadivudine, lamivudine for a number of years.
We were on
So why not use the same thing for PrEP also?
So the use of zadivudine was never proven in a randomised trial. It's true. It probably works.
Maybe the trials were not so exhaustive that time, but
Yeah, well,
whatever.
they tried to do a randomised trial of zidovudine for prevention of occupational transmission, but one was never done in non-occupational. But it's a good point. If you can't use tenofovir, perhaps you've got to look at another antiretroviral, even in the absence of evidence. I think we have to be clear about that.
No, but you must have had the occasion to do something like this, no?
Sorry?
This occasion must have come in your studies when
so
the kidneys were not 100% fit.
Yeah, in
So what
our
is your
setting, in
solution?
general, if kidney function isn't adequate, we don't offer them PrEP. It's a contraindication.
You don't give anything.
Yep, that's right. I know it's an issue, but there are no other drugs proven to work in this area. So we're very much fixated on evidence-based medicine.
Okay.
I've got 5 minutes to go, so I might keep going. Thank you. It's a good point, though. There are individuals for whom PrEP remains difficult. Adherence counselling needs to be part of the baseline. The WHO is very firm that people should never be forced to be taken PrEP. If a person is choosing to take PrEP because they think it's a good idea for themselves, then they're much more likely to be adherent than if they're being convinced to do something they want to be doing. In our setting, our Australian guidelines say 1 pill once a day. We will discuss intermittent regimens with people who don't want to take, who tell us that they don't want to take 1 pill once a day, but we haven't gone as far as the French in allowing both regimens routinely. We tell men who have sex with men that they're protected after 7 days of treatment, and the women after about 20 days.
One small clarification. Are you also giving emtricitabine with tenofovir, or you are giving only tenofovir?
We give both, yeah.
Yeah.
Yeah, yeah. And it is important at baseline that people get warned of a possible startup syndrome. There are many people who start taking a co-formulated tenofovir FTC do get transient nausea, diarrhea and headaches, which usually resolve after a couple of weeks. It's much better to warn people that may happen so that they know what's happening. I'm running behind time, so because of the questions, this is great. So at about a month, that people should come back to confirm they're HIV negative, and this is really important if you've only been able to use a second generation test at baseline, so you're really ensuring they weren't positive at baseline. Discuss and reinforce adherence. It's really great, if possible, to involve peers in this. This is not necessarily the sort of stuff that a doctor needs to get involved with. And then we dispense 2 months of medication. And then from then on, it's 3 monthly visits, confirming that they're still HIV negative, reviewing their adherence. In Australia, we test for STIs every 3 months. That may not be possible everywhere. The US guideline has been 6 monthly. And in other places, given you don't have access to nucleic acid testing, can be problematic. And the recommendation is for 6 monthly testing for renal function. I showed this slide this morning, so I won't spend much time, but you can use these factors that are related to renal impairment issues to guide how frequently you do your monitoring of kidney function. So if they're an old person, they had low, or by old I might mean this is like people in their 40s compared to people in their 20s, have much greater risk. This might lead you to wanting to monitor renal function more often. But the bone issue, as far as we know yet, isn't an issue of clinical importance as it reverses after cessation of therapy. But if people are going to be taking this drug for 5 or 10 years, then these may become issues in the future. I think it's really worth, wherever you're doing this, and including in so-called rich countries like Australia, to talk about, do doctors need to be doing all of this? And I think the answer is very definitely no. I mean, even in San Francisco, you have nurse-led clinics that don't have a doctor on the premises initiating PrEP. We've recently got dispensation from our health minister to allow nurses to dispense PrEP, although not at the very first visit. If you have active community organisations, you can make use of peers for the adherence counselling, because education about what PrEP's about and how to take it may well be better coming from peers than from a doctor. The whole issue, the Achilles heel of PrEP, of adherence, is critical, and you know, you have to make sure a patient understands what daily PrEP means so that they will take it on a daily basis. I think only if we can take a lot of the job of prescribing and monitoring PrEP away from doctors, relieving them of that workload, can we really scale up to the levels that we're going to need. And the WHO goes further than that in stating that it's critical to involve community organisations in PrEP programs right from the very beginning, and that they will have critical roles in educating and training the communities, whether it be sex workers, men who have sex with men, injecting drug users, or whoever. And that, you know, this should not be, you know, many of our HIV services are hospital-based. PrEP has got to go out to the community. You're dealing with completely well people who are taking preventive action, so as much as possible community-based services, and PrEP should obviously only be ever offered as a free choice. And lastly, and I think this really is an issue in the region or in the world, that if a person in a marginalised community feels that they might suffer from identifying as a member of that community in going to a doctor or a nurse to seek PrEP, well, then they're not going to seek PrEP. So really, situations where these communities don't have rights is not conducive to being able to provide PrEP to key affected populations. I'll leave it there. Do we have any more time for questions? Or?
Yeah, I think we can have a couple of minutes for questions if anybody has some. Yes, please just go up to the microphone so everyone can hear.
How long do you continue the PrEP? Is there any time limit or duration limit?
So we don't have any time limit, and this is something that's really emerging. None of the guidelines actually talk a lot about when to stop PrEP. So I think it's got to be based on open conversations with people on PrEP about their life circumstances, because they will change. They'll go in and out of relationships, in and out of phases of their life. But I think one thing we do see in many studies is that some people do become infected shortly after stopping PrEP. So it's very important that if a person talks about wanting to stop PrEP, we're very clear that they need to be doing something else for HIV prevention in the absence of PrEP.
So it's a lifelong treatment, almost?
It depends on circumstances. There will be very rare people who will be lifelong.
Sorry, just related to that, I think would be the question, if you have evidence about resistance then, because I'm sure in my limited knowledge, the problem with PrEP is also people are not adherent all the time and they start and stop and so on, and if you have specifically for tenofovir, then if there is evidence about resistance. In your case, I think you're talking about very limited loss of follow-up in your local experience, but I was wondering if worldwide, which is the trend.
Did you say in drug resistance? I'm sorry.
Yeah, I mean TDF resistance, yeah, so that's been switched to...
It's going to be a different issue around the world. I mean, there have not been many cases reported at all yet, or there's been one definite case reported of PrEP failure. But in situations where you have high levels of primary drug resistance to those two drugs, then you would expect that you may get transmission despite PrEP in some cases. Those cases have not yet been reported, but we certainly need to keep an eye on the data.
We have seen a few, not a few, we have heard from a few clinics that are starting to provide PrEP, that once we have PrEP, people who come into the clinic are more likely to be people with high risk, and some of them, certain proportion of them are people with recent high risk behavior. So that's the time when the role of post-exposure prophylaxis will be there before transitioning into PrEP. So I would like to hear what is the experience in New South Wales? What proportion of people coming in for PrEP are actually more eligible for PEP at the beginning, and how you transition people on PEP to PrEP?
Yeah. So, Nitya, I can't tell you the actual proportion, except that it's very low. The fact that we're using fourth generation tests makes us pretty confident that people haven't, if it's negative, if it's negative today, then it's that probably excludes HIV infection that's been present for more than a few weeks. But the issue of very recent exposure is there. We certainly have had some people who present within 72 hours of a risk episode, starting on 3-drug PEP, and then immediately on finishing PEP, they start PrEP the next day. So they just, in general, they just cease the 3rd drug straight away after that. So there's no gap between finishing the PEP and starting the PrEP.
Great, thank you very much, Andrew. I think we need to move on, but you can talk to Andrew at the conclusion of the session. Thank you very much, Andrew. Our next session, our next speaker this afternoon is Mukta Sharma. Mukta is the Program Manager for TB, HIV and Viral Hepatitis at WHO in Thailand. And she's going to talk to us about the use of preventive TB therapy in people living with AIDS in HIV in the context of ART.
Thank you very much. So, in the spirit of disclosures, there were many disclosures this morning. I'm going to say that I am an unashamed advocate for TB prevention. And today, perhaps you were not really expecting to hear about TB very much, but I want to talk to you about TB. Anybody knows, just a show of hands, about the incidence of TB in Thailand? Is it below 100? Is it over 100 per 100,000? Just those who think yes, it's below 100 per 100,000? Nobody? Okay. So we all agree that TB is a problem in Thailand? Yes? No? I saw 2 hands. Okay, very good. Okay. So TB is a problem everywhere, and this year, 10.4 million people had TB globally, out of which 1.8 million died. And out of those 1.8 million who died, nearly 500,000 were people living with HIV. And as far as I'm concerned, these are people who died absolutely needlessly. We could have done something about it. In Thailand, I hear from many people, do we really need to be providing TB preventive therapy for people who are accessing ART irrespective of CD4 count? Let's look at what the evidence is saying. And so what I'm going to cover for you is, what is the evidence of the additional benefit of preventive therapy in situations where people are being put on ART irrespective of CD4 count. I also want to talk a little bit about what some of the new developments are in prevention therapy. And then I want to go over some of the opportunities and challenges that have been put forward by people in this area. So let me start by just laying out for you what, as a public health community, what is our vision for TB and how we can achieve that vision. The goal for TB prevention, control, elimination is 10 per 100,000 in 2035. So in Thailand, we are at 172 per 100,000. We need to get to 10 per 100,000. In Indonesia, in Myanmar, in Laos, in Cambodia, the level is double. And India has probably the highest burden of TB in the world. 26% of all the world's TB cases are sitting there. And you know that there are 2.5 million people living there with HIV. So what we are finding, looking at modeling and other exercises, is if we continue to just mitigate TB, do the vaccination, do the infection control, prevent TB through good nutrition, poverty reduction, we are going to get to about 100 per 100,000 globally. If you really have very good active case finding, you have very good treatment, and all of those other factors combined, you'll come down a little bit more. But if you really want to eliminate TB, if you really want to get to the goals that we're seeing in some parts of the US, and in other rich countries, you're going to have to prevent TB. So the paradigm is going to shift in terms of not just treating active disease, but in terms of treating latent disease. So I've already gone over this. People are dying needlessly, and there is something we can be doing about it. There is no reason 1.8 million people should die of TB. Now, often people say, when we talk about TB prevention, talk about TB, they say, no, it's an issue in Africa, it's not really so much of a problem here. But I want you to look at the middle, in the Venn diagram, look in the middle, and look at some of the top burden HIV-TB countries in the world. And I want to highlight that here we have China, India, Indonesia, Myanmar, and Thailand. Thailand actually sits on each one of these lists, but I want to just highlight, because we are in the context of HIV, that this is where we are seeing a significant burden of HIV-TB outside of Africa. And yet, what's happening with IPT? So, for a long time, till about 2009, we were getting very little leverage on this issue. And then really from 2010 onwards, things began to pick up, but really, those things have picked up in South Africa, in Africa. If you look at the rest of the world, we've chosen to do absolutely nothing as an effective response to preventing TB amongst people with HIV. Why? We're worried about resistance. We're worried about hepatotoxicity. There are issues with TST availability. And generally speaking, people have thought, oh, TB is not really that much of an issue. If you restore immune function, things will be fine. Put people on treatment. Let's put people on ART. All our problems will be solved. But we're finding that that's not necessarily the situation. So I want to go over what the evidence is in this area. And all of you have heard of Temperano. This was a trial that provided very good evidence for early treatment. But what was not really looked at very carefully in this trial is the role of early ART and IPT. Sorry, I shouldn't have said what wasn't looked at. I should have said what wasn't focused on by the public health community. Everybody focused on early ART, but nobody really looked at that last black line to show you the additional effect of IPT with ART. So you've seen that in both types of settings, early ART as well as late ART, you're seeing that the finding is consistent across the various strata and for different levels of CD4. So the evidence is very clear. Early ART is good, but early ART plus IPT is better, right? So this is evidence from a clinical trial, and when it was presented to some people, they said, oh, but that's evidence from Africa. TB prevalence is higher in Africa. In Asia, we don't have that problem. And I just want to let you know that TB prevalence in this particular country, in Africa, was lower than many countries in Asia. So the results are relevant, irrespective of what the prevalence was. Okay, so I'll just summarize for you what came out of Temperano. What came out of Temperano very clearly was that early ART plus additional IPT has the best results in terms of mortality. But not just that, the independent protection effect of IPT, even if you're treating early on in the course of the disease, is very clear. So this early versus late debate that we've been having for ART, is not a debate really at all. It's clear. We need to do ART early, but we need to do IPT with it. Now, when we talk about doing IPT, people say, oh, 180 doses, how do we ensure adherence? It's very hepatotoxic, et cetera, and it's true. It's not easy to go out and deliver in a health system which has a lot of issues, go out and deliver 6 months of therapy. But things have changed. We have new opportunities, and I particularly want to present for you some of the recent results looking at preventing TB using a 12-week regimen of rifampicin and isoniazid. And what we have here is 12 doses as opposed to 180. So what this study by Sterling et al. Is showing, this trial, is showing that not only is 3 months of rifampicin and isoniazid non-inferior to 6 months of INH, isoniazid, but it also has better adherence and has a better safety profile. So overall, you're getting much more adherence in this group, partly because some of the symptoms that you get, some of the side effects that you get aren't really as much of an issue here. Now, what does WHO say? Since more recently people started listening to WHO in some parts of the world, I wanted to go over what WHO says in terms of latent TB control. So in a very black and white division of the world, we have the low-burden TB countries, which are also sometimes high-income countries and upper-middle-income countries, and then we have the high-burden TB countries, which are often poor countries. And yes, it's true, TB is a disease of poverty. So in both countries, in both types of countries, we say all people living with HIV should be offered prophylaxis. All children and contacts should be offered prophylaxis. But in addition, there are some other groups that we should be looking at, and those are listed here. I want to draw attention to prisoners, illicit drug users, healthcare workers. We are finding in a recent assessment in Thailand that the level of TB in healthcare workers is 5 to 6 times more than in the general population. So there are other groups that we should be looking at, but there is also perhaps now some reason to think that amongst the elderly with diabetes, this is something to consider, because you're getting so much immunological breakdown in the elderly. And as we age in this part of the world, we are finding that a large proportion of the case notifications for TB are coming from the elderly. So an area where the evidence base is still relatively limited, but more and more it's going to become an issue as we go forward. Now, these are the groups that we have to look at. But what we say is, if you're working in a low burden setting, you must do a TST. Why? Because in low burden settings, the prevalence of latent TB will be quite small. If you don't do a TST, you're likely to overtreat. But in high burden settings, while it's preferable to have a TST test, it is not a requirement. So TST and IGRA are not requirements to do preventive therapy. If you have it, good. If you don't have it, there are still ways of excluding active TB and finding the public health benefit for doing this. I also want to say that there has been quite a lot of conversation around TST versus IGRA. There is no difference in the performance of the two tests. The difference is that for doing a MON2 or a tuberculin skin test, the person has to come in more than once. But at the same time, programs have very clear guidelines around this. They know how to implement this. And most importantly, a tuberculin skin test is cheap. It's much cheaper than IGRA, has much lower lab requirements than IGRA. So I want to summarize. We should be doing this. We don't need TST to do this. It's not a condition per se of doing it. And we now have ways of doing preventive therapy which are less intensive from a health system perspective and a program perspective. So I've already covered all of this. I've talked about IGRA and TST. And I'm not going to spend much more time about this. This is just to show you that guidelines are available, that they can be used. So in low burden settings, there is evidence for cost effectiveness of using different types of preventive therapy. You've all heard of the 6-month and the 9-month isoniazid therapy, but there's also now a lot of evidence just around using 3 or 4 months of rifampicin, using 3 or 4 months of rifampicin plus isoniazid, or the most exciting is doing 3 months weekly regimen, the rifampicin and isoniazid. So far, the WHO guidelines are saying do 6 months with INH in a high burden setting. But we're really looking at this issue very carefully, and there's going to be new consolidated guidance on this. And I want to share with you the PICO questions for the guideline. And I only want you to look at the 2 in red. Don't worry about the rest of the slide. So the first question is, should we be offering 3-month weekly rifampicin and isoniazid as an alternative to the 6-month regimen for LTBI in high burden countries? And the second is, what is the accuracy of the WHO symptom checklist to exclude active TB? In some populations, we are finding that there are some issues with that. A good example is the elderly who might be diabetic. It's not automatically clear that the symptoms that we work with usually are often being very sensitive to being able to pick up TB in those groups. So that's work that we are looking at, and we should have answers very soon on these questions. Now, these vastly simplified dosings under the rifampicin and isoniazid regimen have much fewer requirements for the health system, as I mentioned. What that means is your nurse doesn't have to do DOT, doesn't have to do directly observed therapy. They don't have to be chasing up a patient. You don't have to be worried about a loss of adherence there, which is going to lead to resistance. And the issues around side effects, managing side effects and hepatotoxicity are much better managed. The other question that comes up is always people being worried about interactions. And I just wanted to say a little bit about this. For this new regimen for IPT, for prevention, there is no interaction with efavirenz. There is no interaction with raltegravir. We're looking at data for interactions with dolutegravir. At the moment, there is no clear answer. There isn't enough data. So I just want to highlight that rifampicin, the RHP regimen is not the only option. You could be looking at other ways of doing this as well, in case there are people already on HIV treatment who are on a dolutegravir-based regimen. Okay, now comes the issue of cost. Everybody talks about cost when it comes to TB. And when we talk about TB prevention, people start saying, oh my God, that's so expensive. And I find that, coming from the HIV world, coming from the PrEP world, a very, very annoying conversation. Because we're happy to put lots of people on 2 drugs. And we're happy to pay more than $100 for those drugs. But when we talk about prevention for TB, suddenly everybody starts counting the dollars. Now, the new rifampicin regimen is on the expensive side. It is about $70. And if you look at the cost of TB drugs for first-line TB, it's very cheap. It's about $29 to $30. So here you have a situation of prevention actually costing more in terms of drugs than treatment. But again, for HIV, we're happy to do that. We think it's a good public health alternative. But in the TB world, people aren't willing to think of it like that. There is much more nervousness around that. And that's largely to do with not so many patient advocates in the TB world, not so many people stepping up and saying, sorry, this is not good enough. And also because TB is still a disease of the poor man. And TB is an issue in poor countries which have very limited health budgets. So you're getting both of these issues coming together to really lead to a lot of underinvestment in TB. And I'll give you an example. In Thailand, we spend $300 million a year on the HIV program. $300 million. Anybody want to take a guess on what the TB program spends? The National Health Security Office spends around $11 million a year on TB. So you're really seeing these very strong inequities between public health systems in terms of how they address diseases. And this is something we need to start thinking about. And this pattern is repeated in country after country after country after country. The other issue seems to be that many physicians say, yeah, TB is a re-emerging infection. And you sort of look at them and you go, no, it's not re-emerging. It's been here. It's not like we really controlled it, brought it down to incidence levels like 50 per 100,000, and now suddenly we're getting a resurgence. It's been here, but we've chosen not to do anything about it. And that, again, links to the whole issue of advocacy and activism. So I think that needs to change. In the TB community, we need to be working much more with patient advocates who've really taken the HIV response this far. And this is an appeal to those of you who are sitting in the room that talk about TB, because there are people who are dying of TB who shouldn't have to die, who are living with HIV. So I'll stop here, and I won't go over the conclusions again, but I just want to acknowledge my colleagues who've helped with this work, Annabelle Badley and Hamada Yohai, as well as the WHO TB program in Geneva. Thank you.
Thank you, Mukta. That was very interesting. Does anybody have a question? Yes, can you please go to the microphone? Just while you're on the way to the microphone, I'll just ask a quick question. Mukta, what, in the Thai National Treatment Program, what's the National HIV Treatment Program? What happens with TB screening?
In Thailand?
Yeah.
Okay. So, you want a short answer or a long answer?
Probably short, because we don't have much time.
So basically, it's recommended, but more and more, because people feel that we've started ART irrespective of CD4 count, we don't really need to be looking at this, as the incidence of TB is not going to be very high in patients who are on ARV, who have good immune suppression, good immune reconstitution. Now that all works really well in a place like Bangkok. You know, you're in a nice private hospital, Bangkok's rich, the incidence of poverty is really low. You go out to the northeast, or you go to the south, things begin to look very different. And TB screening is not happening adequately using GenExpert. So, you know, it's hard to detect TB in the same way amongst HIV-positive people. You may have more extrapulmonary TB, et cetera, et cetera. And so the tendency is for people to do some of the symptom screening, but not necessarily to use some of the more sensitive and the rapid methods that are available for diagnosing TB. So that work has started more recently, in the last year or two, and there is a good push for that. In the country. Related to this is the whole issue of how many people who have TB and are HIV positive are put on ART in the country, and that percentage is about 70%. So, our context is we're starting treatment at a relatively low CD4 count. It's gone up to about 200. The proportion of patients who should be on ART is much lower than in many African settings. And we're not using some of the most sensitive and rapid methods to diagnose TB in this population. We could be doing much better.
Thank you.
Hello, thanks for the wonderful presentation. So I'm from Myanmar, and in our country, many people are on BCG vaccination, and tuberculin skin test is positive, maybe because of the cross-reaction with the BCG vaccination, and the test like interferon gamma release assay is not available. So do we really need to distinguish or exclude the false positive reaction, or if yes, how can we do that in the result limited setting? Thank you.
It's a good question, and we see this in many settings, concerns that BCG vaccination may actually be leading to TST positive tests. And really there are two ways of looking at this. One is to see if a chest X-ray is possible. In Thailand, it's very easily available. So increasingly, WHO is saying, if you cannot exclude it clinically, if you cannot exclude it by examining the patient, look at doing a chest X-ray. And the other option is look at the gene expert. That's going to be a good way of considering this issue. But really, your first thing would be try and exclude it from a symptomatic clinical perspective. If you have resources available, do a chest X-ray, and if not, if there are more resources available, follow that up with a gene expert. That'll give you a much better idea of this.
Thank you.
Thank you very much, Mukta. I think we should move on in the interest of time. Our last speaker this afternoon is Alain Volny. Alain's from the European AIDS Treatment Group, and he's going to talk to us about the important role of the community in research and implementation.
Good afternoon. It's an honor and a pleasure to be here despite my strange voice today, and I want to thank the organizers for inviting me to speak here. And contrary to, how do I move this? Yes, contrary to tradition, because usually we do thanks at the end of a talk, I want to extend my special thanks to Gus Cairns, who's a prominent member of my group in EATG. These disclaimers are here. He has largely inspired this talk, and his disclaimers are here. I'm not going to read all of them, but I'm not a scientist like him. I'm not a scientist. I'm not a statistician. And I work for an NGO which is partly funded by pharma. These are my disclaimers now. I stole them from him, and he agreed. Now, what I want to do here is outline the added value, remind, if needed here, the added value of community involvement in HIV research. And by research, I mean all HIV research, from social science to cure, and perhaps even more to prevention research, beyond participation of people without HIV, actually, from the community, but as subjects, beyond being somehow used as just subjects. One might think that I'm sort of diverging from the topic of this session, but I'm not, because I believe that having people being involved right from the beginning, people from the community, right from the beginning of a research, will help pave the way in a smoother way for the implementation later on. It is my creed anyway. I have to introduce my group first. It might look like a very, it's a copy actually from our website, and you will look at it. It's www.eatg.org. What's important here is that by European AIDS Treatment Group, we mean a group of nationally based volunteer activists from 47 countries, including countries as far as Eastern Europe, but also Central Asia, Turkey, and Israel. So it goes pretty far. I won't go into the details of all the projects we're working on, but you see scientific research, policy advocacy, and some portfolios like viral hepatitis, TB, access affordability, HIV cure, and so on. But on this website, you also have position papers, including one that was released in October 2015 on prevention. It's a position paper on prevention, and I have to quote and read that we call, with this paper, we call for the funding of coordinated research developed with the full involvement of affected communities to further understand which prevention programs are most effective and acceptable in European context. Again, we're from Europe, so we're talking about Europe. And I smiled when I took this from the website and put them on my notes here, because I was going to tell researchers here that you guys cannot, it implies that you researchers cannot further understand which prevention programs are the most effective without the support from the community, and I hope you agree with me. However, what do we mean by community? Words like this often need to be clarified, and in 2011 there was a great group from the Global Advocacy for HIV Prevention. Together with UNAIDS, they met and produced some guidelines called the Good Participatory Practice Guidelines for Biomedical Prevention, in which there is a great mandala that will sort of illustrate pretty well what a community is. Not as nice as this Buddhist Tibetan one. I looked for a Thai one and I couldn't find it on the internet, so I found a Tibetan one. But this one, what do we have on this mandala? You have, and by the way, mandala has several meanings, including community. A trial participant is at the heart of this mandala, and I insist that trial participant is already a powerful word. It doesn't mean like I'm just going in a trial and let's see what happens. It's really signing a consent and engaging, committing to doing something. And this person, woman or man or transgender, would be, surrounded by other community stakeholders, broader stakeholders, national ones and global ones. And the closest are the family members, obviously, the friends, the colleagues, the organizations around them who give them support. I was actually surprised to find that nowhere the word sexual partner appears on this mandala. I wish they had put life sexual partner, but also night sexual partner, and also maybe an hour sexual partner. These things happen in reality, but they're not here. However, this is still a useful tool. It can also translate into this perhaps easier to read list. I'm not going to go through all of it, and I'm going to be shouted at by my colleagues because they had asked me and I forgot to add at the top of the list of activists, drug users activists and also sex workers activists. Mea culpa, I forgot to put that. But what I want to highlight here is that HIV treatment activists like me might not be HIV prevention specialist activists, who might not be LGBT activists. And in this list you have also the potential users of your method, the people at risk. You have at the bottom the healthcare providers and so on. What matters here actually, the strongest message that I have here is that these categories, most of them will overlap. Again, we know that HIV does not discriminate, so that might be one of the reasons why we know that these categories would overlap very easily. So why would you, if you're a researcher, involve the community in a trial? If you ask me the question, I would say to you that I definitely know that it will at some point bring benefits to my community. Now, if I were a researcher, I would be answered by community people like me, that community will help define or refine the definition of target populations and of research needs and non-needs, have an impact on a trial acceptability and design, certainly, support the network and the testing phase of a trial, support the conduct, and by conduct I mean really getting involved to run the trial with the scientists, disseminate results, preferably in a non-Lancet language, you would agree with me, and advise in a continuous process on rollout, marketing, and implementation. If you look at this in more detail, this question at the top, who is the population, can be divided into several questions like who needs the intervention, who to target, who are the supporters, and who will spread the word. There are surprises, like some years ago in 2006, we had the results published at CROI of a community research for the IPREX project then, which were led, it was a survey led in Peru and Ecuador where no less than 7 groups of MSM, different groups of MSM were identified. with, for each of them, different concerns, knowledge, level of awareness, and need. You cannot speak to, and we know this, you cannot speak to a person, MSM, a man who has sex with men, but does not identify as gay, as you would do to a person who has sex with men, a man who has sex with men, but does identify as being part of the gay community. Now, what are the research needs? Community, well, sometimes different needs from researchers, we know this. Researchers may underestimate the effect of certain factors. I've been through this at the end of the 90s when we had lots of meetings with the pharmaceutical industry and health authorities in Europe, telling them we have a problem with lipodystrophy and lipoatrophy. Our bodies are changing, our faces are changing, would you listen to us? And they would not, and probably it took them 1 year or two before we saw some publications in conferences where we went there. Researchers may also overestimate the willingness of community to use strategies with obvious advantages, identify areas of concern, misunderstanding, ignorance, and also factors that may inhibit the participation, uptake, and use of the method that they propose. So definitely, you need to have community actively involved in prevention trial design, right from the beginning in the design, to discuss with them, etc. This is not an easy task for anyone, even from community advisory board members, but these people, HIV treatment people like me, activists like me, who are part of community advisory boards, are familiar with protocols, trials, data safety monitoring boards, and so on, and they can give advice and even train other people who might then become the people that researchers will interact with if time is an issue. Of course, the participation of community will probably increase the acceptability of the method. It will be a way for researchers to avoid obvious pitfalls, increase the way to check the ethics for a trial, and we know this, community may know more than researchers about risk practices and behavioral prevention. An example is what was done for the PROUD trial in England, PrEP PROUD trial. First, there was an awareness campaign which started with HIV advocates at the BIVA conference in 2011. See the time, how early that was. And then 2 meetings with all stakeholders, plus many conference calls between researchers, but also activists and workers, HIV prevention activists, and outsiders. And by this I mean, in particular, activists in the UK who were more trained with the idea that the only message would be condoms and simple messages and nothing else. So that was quite challenging for them to participate in those meetings. Community networking testing, this has to be with the publicizing and the advertising of your trial, and it will certainly help you recruit. The French Community Advisory Board called TRT5, in which there is the largest AIDS organization called AIDS, organized several meetings in the main French cities. I was part of them, and I can tell you that was very interesting in terms of the most extreme negative attitudes towards having PrEP, distributing PrEP, having a trial on PrEP, and very positive attitudes. The scope was really broad between the two options. But it's not only about going to inform and publicize and advertise, it's also about getting feedback from those debates and potentially adjust your protocol according to what you've heard in these discussions. So it's really an interactive process. When I said earlier that I think communities should be involved in really running a trial, I meant that they should reach the top level of the structure of a trial, like participating in a steering committee, being a data safety monitoring board. Usually people are very afraid that, these confidentiality issues and everything. The ethics board, publicity, information, referral, peer support and counseling, and of course patient advocates. Part of the trial again. Now, the dissemination, communication of the results, I won't spend too much time on this, except that I have a personal conflict with this. I think most of researchers I know, friends sometimes, have this perception that this is the only obvious role for community. Please communicate the results of my research and nothing else. However, it is true that community has the media, has the skills to write properly on science in the appropriate language towards other people, towards peers, for example. But it's not only about writing, it's also about having, like what happened in some microbicides trial, it's also having meetings with women who participated in the trials and explaining to them what they would consider bad results. Why are they bad results? Why are they not effective results, and so on. And then advising on rollout, marketing, implementation. I won't spend too much time either on this because we all know that a successful intervention is useless if people are not aware of it, find it too hard to use, have heard it's dangerous, don't trust research in general, etc., etc. Now, if you do not involve community in your trial, what are the risks? Well, I think the major risk for not involving is overt hostility. We saw 2 PrEP trials at least cancelled years ago in Cambodia and Cameroon. We saw a lot of controversy around the Thailand with drug users, the PrEP study with drug users. And at the moment we are seeing with the trial run by Gilead, this sort of new PrEP trial going on, we are seeing a controversy, and I would invite you, because I won't go too long on this either, I would invite you to go on the body.com website to see the opinion of some leaders of the community about the lack of involvement by community from Gilead. Now, trust may not produce a positive efficacy result, but will produce a clearer result. It happened in the FACTS 001 trial, and I will come back to this later. I wanted to show you also a model for community consultation. This is a very, very busy slide. It's not really visible, but briefly what I can say is that it's an ideal world of research where interaction is ideal between community at the top and researchers at the bottom is a very interesting one. I don't know if you're going to have the slides. It's readable when you have the slide on a laptop. You can start with the issues at the extreme left, issues raised within community, and at the same time, epidemiological data that are collected and that can produce already together qualitative research up to the trial itself, the DSMB, the Trial Community Advisory Board, the dissemination, that's the oval part, dissemination of results, and then the implementation phase afterwards. Now, some history. I'm French, and I am part of the lucky countries where actually today PrEP is available, Truvada PrEP is available. It's a very busy slide and you do not need to read all of it. What I just want to point out is that community also has a role in implementation by putting pressure. It started in 2013 when ED, the organization I mentioned before in France, asked the French drug agency to grant Truvada a temporary recommendation of use, and I will use RTU to simplify things here because that's the French acronym of daily PrEP. Then in 2014, the Proud and Hypergate trials transitioned to open label, and ED asked the health minister to speed up the license review. Just to stop here, we must understand France being part of the European Union, any drug has to be approved first by the European Medicinal Agency before being approved before being reviewed and approved eventually at national level. But in France, we have this RTU system, which allows to not wait for the European approval of a technology or drug, which is a good thing. It also allows, by the way, to collect data. In 2015, this is just 1 month before the publication of the Proud and Hypergate results, ED was auditioned by the French drug agency to see if they would get the RTU license review. And right after, well, of course, after the results of Proud and Hypergate, of course, it gave ED more momentum than ever, and they started to put more pressure on the health minister and also even threaten her of importing illegally generic Truvada and implement PrEP in the ED center, where already counseling and TROD is happening. So there is already the structure they would have had the structure to distribute PrEP in the ED centers. So this pushed the health minister to finally give up on her resistance, on her own resistance and the government's resistance. And finally in 2016, January, we have had the use of the RTU in France for Truvada as PrEP. And in June, that was extended to STI clinics because in January, it was still in the hospitals. You're talking about people who do not have HIV, who had to go to HIV centers as if they were patients when they are not patients. The EMA, European Medicinal Agency, is a sad story about PrEP, because the FDA had already approved, based on the IPREX, not even PROUD or IPREGAY, but IPREX and Partners PrEP data, they had already approved Truvada for PrEP. But the EMA refused actually to consider, they found all sorts of reasons, they refused to consider reviewing the licensing of Truvada for PrEP, and it took them 4 years to finally, last year in July, made the decision to grant authorization for TDF-FTC to be used as PrEP in the European Union, meaning again that now, only now, countries like Holland, Belgium, Germany would have now to discuss with their own drug agency. So a real waste of time. And this happened despite pressure from community. They had no authority, I think. They were not representing community, the people who needed it. And they were not transparent about this. But we found out that the rationale was the concern that PrEP users might use fewer condoms, exactly what PrEP was about, you know. So 4 years wasted. And I agree with Simon Collins, my colleague in EATG, that this was a moral rather than a scientific decision. By the way, the EMA is not supposed to give moral statements about something. It's not supposed to go into pricing, for example. It's supposed to just analyze efficacy and safety of a medicine. The good news that might come in 2 months is Scotland. It's happening in Scotland. I have to explain again that the PROUD study took place in England. But despite the fact that it took place in England, it was so successful, the NHS, the National Health Service, decided that it would not reimburse, so people would not get it for free throughout the health system in England. The whole thing went to court, and the organization that went to court won, which means that in the end, the NHS found a sort of compromise by opening last December, last month only, a trial that will welcome 10,000 people to receive PrEP, but this is, of course, coming from research budget more than from the National Health System budget. But Scotland has a different system. The health system is different, and they have, what do you call it, a sort of medicinal committee. The Scottish Medicinal Committee actually received a submission from the HIV authority, which had itself endorsed a report. This is very complex, but had endorsed a report by a short life working group, which was actually organized and led by a community organization called HIV Scotland. That's my point here. And additional to the report that's already endorsed by the highest authority, there will be a community submission in February next month, and the final decision by the Scottish system will be in March and published in April. I don't know why. This is probably a regulation in Scotland that I don't know about. So, in conclusion, what I wanted to say is that I hope I've convinced you that by applying all these guidelines that we have in this good participatory practice, this is a benefit for everybody, for research as well as for community. It looks very complex when you go through the model that I showed to you, this list of things to do, like the FACTS 001 trial. I want to come back to this because the FACTS 001 with microbicides, the trial, the efficacy was not good, but there was not the disparity that was seen in other trials with microbicides. That disparity in voice and FemPrep trial with microbicides, the reported adherence by the women who used the microbicide in FemPrep and in voice, and the actual adherence, there was a large disparity between the two. In FACTS 001, which applied this principle, there was no such thing, because the researchers are now saying today that's because we put so much effort in educating the community around this trial, not only the participants, but everybody around. So I hope I've convinced you of the interest of having community people involved in trials and research, and then in implementation. My last slide is to thank, again, Gus Cairns, Sean Hossain, my colleagues in EATG, but particularly Sean Hossain in Canada, Simon Collins, Rebecca Webb, Bruno Spear from ED, and my dear loving husband, Eric Flutlo. Thank you very much.
Does anybody have any questions for Alain?
Is this Nishaya?
Thank you very much for the wonderful talk. And in Thailand, we based our research on that GPP guidelines, and we call that nice figures of stakeholders as an onion. Because it looks like a peel of onions. It's not question, but I just would like to get your comments on how you think is the best way to convince the funder right now to really pay interest in how community involvement or community engagement is for the studies that they are funded. Because right now, when you look at the NIH grant application, you have to write a certain section about community engagement, and people are just simply put community advisory board as a structure for community engagement. But we know that in reality, that is not the only or the sole ways of engaging community, and may not be a very effective way of engaging community as well. So do you think that there is a role from community to convince the funders to really pay attention in terms of reading the proposal and then follow up with the report, regular reports to the funder on how seriously researchers are paying attention to engage community. So it's not only at the beginning of the study and then at the end when you want to do result dissemination that you think of community engagement. So what will be your best suggestion to the funder?
I look like I'm hesitating because I don't want to give you an easy answer to a difficult question. My group was founded in 1991, and the European Community Advisory Board was founded probably exactly at the same time, in a time in Europe when we didn't have those treatments that we have today, and we were really organized around this. It was like an emergency situation. I'm not saying that PrEP is not an emergency, but I'm saying that in those, so along the years we got this credibility throughout meetings. It wasn't easy. I mean, I remember meetings in London with a pharmaceutical, I won't name it, a pharmaceutical company where we had security officers with guns waiting for us. So they really, I mean, you build a trust along the years with community, but you have to start at some point. And I think if you have HIV organizations in Thailand, and there are, I know some of them, you have to invite them first to maybe do like the PROUD trial, you know, invite them and inform them of this is the trial that we want to put in place, or the program that we want to put in place, what do you think, and get feedback. And then maybe invite some of those funders people and participate so that you can build trust all along the years. When I mentioned being part myself of a DSMB for a trial in Europe, what I didn't say that it took us years to get access to DSMBs. This is something, you know, researchers didn't like because they thought we would breach confidentiality the next day after hearing, you know, an accident happen, there was a stroke, somebody was taking this drug and had a stroke, that we would write about it the next day. So it takes a lot of time. But if people are really committed to participating, I'm talking about people from the community, then the trust will be built and things will go smoother. But that's not an easy answer, actually.
I think that we should finish because we're a bit over time. But
Thank you.
I'd like to thank Alain and Mukta and Andrew for excellent presentations, very thought-provoking presentations this afternoon. So please join me to thank the speakers.